Okay, thank you, Allison, and thank you everyone for joining this afternoon. The Center for Medicare and Medicaid Services published their final Medicare Physician Fee Schedule rule for 2015 in late November of 2014. The rule brings a number of changes that providers, doctors, practice managers need to understand about a number of different areas. Today's webinar, we're going to center around understanding those changes, how it's going to impact your practice. First, we'll do a quick review of the fee schedule, discuss the key provisions, understand the impact of these provisions by specialty, take a moment to examine changes in PQRS and the value-based modifier, and conclude with some additional changes that CMS has introduced in 2015, one namely being the changes that they've implemented to the 59 modifier. Because there's going to be a lot of information thrown at you in a very short period of time, we're going to include a list of resources at the end of the webinar that you can use for further information. So with that, let's go ahead and get started. So when looking at the Medicare fee schedule, it's established back in 1992, replacing reasonable and customary charge system. It's a formula developed by CMS that determines reimbursement amounts. The formula on itself is pretty straightforward. However, all the nuts and bolts associated with the calculation of each of the individual components is more complex, and it's funded by Medicare Part B. So let's get into, excuse me, a little bit of the specifics. So the fee is composed of costs associated with physician work, practice expense, and the professional liability insurance associated with providing the services. Each of these elements are assigned a relative value unit for each of the individual CPT components. The work RVUs reflect the relative time and intensity associated with furnishing the services to Medicare beneficiaries and typically make up about 50% of the total payment associated with the service. Practice expense RVUs reflect the cost of maintaining a practice, such as renting office space, staff cost, equipment, buying supplies. And the malpractice RVUs reflect the cost of the malpractice insurance and the risk and sensitivity of providing the individual service. These RVUs are then adjusted by a geographical practice cost index, or more commonly known as a GPCI. The GPCI accounts for the geographical variations in cost of practice and medicine in different areas of the country. For example, the cost of practicing medicine and the cost of living is going to be higher in the Northeast than it is going to be in the Midwest. That GPCI takes into consideration those differences. The sum is then multiplied by a dollar conversion factor. And the statute specifies the formula by which the conversion factor is updated on an annual basis. This formula specifies that the update for a year is equal to the Medicare Economic Index and adjusts ups or down depending on how actual expenditures compared to a target rate called the sustainable growth rate. Now the MEI, or the Medicare Economic Index, is a measure of inflation faced by physicians with respect to their practice costs and their general wage levels. Now the SGR is calculated based on medical inflation, projected growth to the domestic economy, projected growth in the number of beneficiaries in the fee-for-service Medicare, and changes in laws and regulations implemented by Congress. Now, in recent years, Congress has taken action to establish a specific update amount, and I'll talk a little bit more about the SGR in the upcoming slides. Now, as stated previously, the 2015 Medicare fee schedule brings a number of changes that doctors and practice managers need to understand in order to be able to navigate through the changes of healthcare and understand from a reimbursement perspective. Instead of having you read through the 1,100 plus pages, we've pulled many of the key provisions out that are listed on this slide today, and we're going to go through each of them in a bit of detail to get a better understanding of some of the changes that are going to be coming. Now, the Medicare Sustainable Growth Rate Formula was enacted by Congress as a part of the Balanced Budget Act back in 1997. The intent of the formula was to control the growth of Medicare spending for physician services by tying the Medicare payment for services to physicians to the overall status of the economy. So basically saying if the U.S. GDP does well, you get more money. And if it does poorly, you get less money. for the same services that are provided. This is common theory in business and practice across the board. However, there is a fatal flaw when it comes to implementing this within healthcare organizations. The SGR doesn't really control volume and, in fact, cuts payments without regard to the quality and efficiency of care provided by an individual physician. Every year, the formula threatens to impose steeper cuts on the Medicare fee schedule. And since 2003, Congress has actually stepped in and intervened 17 times with legislation overriding these reductions required by the SGR, including most recently in the Protecting Access to Medicare Act last year that actually stopped any changes or reductions in the Medicare fee schedule. So in looking at the Protective Access Act of Medicare in 2014, it provides for 0% updates for services furnished between January 1st and March 31st. So within the first quarter, the Congress, the legislation that was updated by Congress last year will actually not impose any changes. However, current law does require that the fee schedule rates be reduced by an average of 21.2% come April 1st if Congress doesn't step in and intervene again. So for those for every 1,000 E&M services that you're providing, by nature of this, unless Congress steps in, we're going to be taking about a $21,000 haircut for those same services and receive less reimbursement than we received last year. Now, many groups have advocated that the flawed SGR formula needs to be replaced with positive, predictable, and permanent payment updates. One of the major roadblocks in this has been the high cost of complete repeal in this formula. I think there will be changes to the SGR coming eventually in order for us to be able to maintain and balance the budget and maintain the increase of the Medicare beneficiaries that are coming out. We should know more in the coming weeks to months whether or not Congress will repeal the 21.2% reduction that's called for today. But as of now, the reduction is in place to begin April 1st of this year. So with the bad news of the decreased reimbursement, we do have some good news. Starting now, Medicare will be paying providers to coordinate the care of Medicare beneficiaries. CMS will make a separate payment for non-face-to-face chronic care management for Medicare beneficiaries who have a multiple, meaning 2 or more, significant chronic conditions. Now, this change acknowledges the widely recognized fact that physicians already spend a great deal of time managing the health of their patients, sometimes spending countless hours coordinating care outside of a typical patient visit. Physicians have not been historically reimbursed for this work, and moving forward, they're going to be. CMS now states it will pay for a non-face-to-face chronic care management service, including ongoing development and revisions of care plans, communication with other treating providers, and medication management. Medicare is going to allow a $42 reimbursement rate for the code 99490. This is what designates a non-face-to-face chronic care management encounter. Patients must have, again, 2 or more of the chronic conditions that are expected to last at least 12 months, and that place the patient at significant risk, acute exacerbation, decompensation, or a functional deadline. To build this code, physicians or their clinical staff members must spend a minimum of 20 minutes performing the CCM services. Direct supervision is not required, which means that nursing staff or non-physician practitioners are going to be able to render the CCM, even if the physician is not in the office. Physicians may bill for this code no more frequently than once per month per qualified patient, but it can be billed once per month as long as the 20-minute minimum is met. And then the patient, as with their normal Medicare beneficiary, is going to be responsible for 20% coinsurance of the $42. Most primary care physician groups like the AAFP applaud the step in moving forward and then eventually go farther and institute some risk adjustments. Although clearly targeting the primary care specialists, there is nothing that limits other specialties from participating in the chronic care management initiative that's being set forth. Now, with the good also comes, a laundry list of requirements that physicians are going to have to comply with that may be a barrier for some, regardless of your specialty. There are a multitude of rules accompanying the opportunity for the reimbursement. Some of the requirements are ongoing access to the practice. This includes access for the patient for 24 hours a day, 7 days a week. Continuity of care, meaning the patient should be able to get successive routine appointments with a designated practitioner or a member of their care team. Systematic assessments of patients' medical, functional, and psychological needs. This includes timely preventative care services, medication reconciliation, oversight of the patient's ability to self-manage their own medication, creation of a patient-centered care plan that is documented and serves as a comprehensive plan of care for all of their health issues, management of the patient's care transition among providers and settings, enhancing opportunities for a beneficiary or the caregiver to communicate with practitioners via the phone, secure message, internet, or other asynchronous methods. The AFP urges CMS to include more than 20 minutes of the clinical staff time in the direct practice expense inputs for the code. They said 60% would be more appropriate, and also suggest unbundling some CPT codes, which allowed for add-on codes to capture additional time spent. So one of the things that's recommended is that for practices that want to participate in this, they need to devise tools that can keep track of how much clinical staff time is spent to ensure that it reaches the 20-minute threshold. It doesn't have to be 20 minutes per day. It could be, 5 minutes spread across 4 days of the month. But this is going to be one of the areas that's going to make it difficult in order to ensure that you're documenting the appropriate time that's spent on the patient rendered throughout that month, even if it's in small increments. In the absence of a cloud-based revenue cycle management system with flexible rules engines, it may be difficult to configure this and to ensure that the billing is held in the system so that it's only billed out once per month on a continuous basis. And finally, CMS hasn't published the list of diagnoses that are going to be considered in the chronic care, which are eligible for the chronic conditions that meet the definition of the code. It is expected that in the next 4 to 6 weeks that these will be supplied by CMS in order for us to begin billing under those circumstances. Now, consistent with the amendments to the Affordable Care Act, Medicare has engaged in a vigorous effort over the past several years to identify and review potentially misvalue codes and to make adjustments where appropriate. Some of the major misvalue code decisions for 2015 include hip and knee replacements. CMS is adopting a valuation change that reduces payments for hip and knee replacements. The final payments were higher than were recommended by the AMA. While CMS indicated that it would consider further changes, the agency decided that further reductions were not going to be warranted after considering information and public comments. In looking at radiation therapy and gastroenterology, CMS adopted code changes for gastroenterology and radiation therapy services until they can go through the notice and comment rulemaking proposals values for 2016. As a result of this decision, CMS is not going to recognize some new CPT codes and will create specific G codes in place of the CPT codes to continue current payment rates through the calendar year 2015. For radiation therapy, CMS is proposing to refine the way it accounts for the infrastructure costs associated with radiation therapy equipment, specifically removing the radiation treatment vault as a direct expense when valuing radiation therapy services moving forward. After considering public comments, the agency decided not to finalize this proposal, but it is up for reconsideration whether the vault is a direct or an indirect cost through rulemaking in future year. In looking at epidural pain injections, CMS reduced payment for these services last year under the Misvalue Code Initiative. In response to concerns from pain physicians regarding the accuracy of the valuation, CMS proposes to raise the values in 2015 based on their prior resource inputs. However, because the inputs of these services included those related to image guidance, it was proposed to prohibit separate billing from image guidance for calendar year 2015. The final rule and policy is proposed to avoid duplicate payment for image guidance and epidural injections. The agency has asked the RUC to further review this issue and make recommendations on how to value epidural pain injections in the future. And finally, CMS finalized its proposal to update the agency's practice expense inputs for X-ray services. This is a direct reflection that X-rays are currently done digitally more often rather than utilization of analog film. So 0-day, 10-day, and 90-day surgical global packages have always been a part of the physician fee schedule. 0 global codes include the surgical procedure and the preoperative and postoperative physician services on the day of the procedure, including visits related to the service. 10 days include those services, visits related to the procedure during the 10 days following the procedure, and those 90-day global codes include the same services as the 0 global codes, plus the preoperative services furnished 1 day prior to the procedure and then a 90-day duration period following the procedure. The OIG has identified a number of surgical procedures that include more visits in the global period than are currently being furnished. They have concerns that post-surgical visits are valued higher than the visits that were furnished and billed separately by other physicians, such as internists and family physicians. And then they're going to actively look to assess whether or not there's a better construction of the bundle payment methodology and surgical services that are going to incentivize care coordination and care redesign across an episode of care moving forward in 2017, and then following in 2018, looking at a 90-day global services review. One of the things that Medicare recognizes in the 2015 physician fee schedule is the ability of how medicine's changing to go to some of a telehealth model. CMS is now adding the following services to the list of services that can be furnished to Medicare beneficiaries under the telehealth benefit. These include annual wellness visits, psychoanalysis, psychotherapy, and then prolonged evaluation and management services. So as required by Medicare law, review and, if necessary, adjustments to malpractice RVUs are to be done no less than every 5 years. For calendar year 2015, CMS conducted the 3rd comprehensive review and update of malpractice RVUs and then proposed new malpractice RVUs for all the services. CMS is adopting new resource-based malpractice RVUs based on updated professional liability insurance premiums and largely still paralleling the methodology that was used in 2010 when the last updates were made. Also required by the Medicare law, CMS adjusts payments under their fee schedule to reflect local differences and cost of operating medicine, what we discussed earlier as the GPCI. For calendar year 2015, CMS is using territory-level wage data to calculate the work GPCI and employee wage component of the practice expense GPCI for the U.S. Virgin Islands. The calendar year 2015 GPCI also reflects the application of the statutorily mandated 1.5 work GPCI floor in Alaska and the 1 work GPCI floor for all physician fee schedule areas, as well as the 1 work GPCI floor for frontier states such as Montana, Nevada, North Dakota, South Dakota, and Wyoming. However, given the statutory 1 work floor is scheduled to expire under current law on March 31st, these GPCIs now reflect the elimination of the 1.0 work GPCI floor from April 1st through December 31st, 2015. Now, for those practices legislated under as a provider-based practice, CMS is going to begin collecting data on services furnished in off-campus provider-based departments by requiring hospitals to report a modifier for those services furnished in an off-campus provider-based department of the hospital, and will begin requiring physicians and other billing practitioners to report these services using a new place of service code on professional claims. Data collection will be voluntary for hospitals in 2015, but beginning in 2016, it's going to become a requirement and be mandated. The new place of service code will be required for all professional claims as soon as it's available, but again, it won't be mandated until January 1st of 2016 in the coming year. The Open Payments Program, Physician Payment Sunshine Act, establishes a system for annually reporting and increasing public awareness of financial relationships between drug and device manufacturers and certain healthcare providers. The Open Payments Program requires applicable manufacturers of covered drugs and devices and medical supplies to report payment or other transfers of value they make to physicians and or teaching hospitals to CMS. It also requires applicable manufacturers and applicable group purchasing organizations, GPOs, to report certain ownership or investment interest held by the physician or their immediate family members, and payments or other transfers of value made to physician owners or investors if they hold ownership and investment interest at any point in time during the reporting year. Now, in response to questions and experience administering the program, CMS is finalizing 4 changes to the rules. They're deleting the definition of covered device as it was duplicative of other areas stated within the regulation. They're deleting continuing education exclusion in its entirety, eliminating the exemption for payments to speakers at certain accredited or certifying continuing medical education events. This will create more consistent reporting requirements. It will also be more consistent for consumers who will ultimately have access to the reported data. CMS is going to require reporting of the marketed name and therapeutic area or product category of the related drug, device, biological, or medical supply, unless that payment or transfer value is not related to the particular non-covered device. They're also going to require applicable manufacturers to report stock options, or other ownership interest as a distinct category. This will enable to collect more specific data regarding the forms of payments made by applicable manufacturers. Based on public comments, these manufacturers need to update their systems according to the new requirements, and the changes for data collection will be mandated come January 1st, 2016. Now, until now, there haven't been any separate codes to pay for a higher cost 3D mammography compared to the 2D mammography. Since around 2000, 2D digital mammography has been paid at a special payment rate temporarily provided by law for digital mammography. To ensure that the higher resources needed for 3D mammography are recognized, CMS is now going to pay for the 3D mammography using add-on codes that will be reported in addition to the 2D mammography services. And then they're going to revisit the 2D versus 3D mammography for 2016 when it reviews coding and payment for all mammography services under the misvalued code initiatives, excuse me. me. Now, in the ruling, CMS estimates that payment impact on the physician fee schedule service of the proposals contained in the proposed rules. Of course, if there are year-to-year changes in the volume and mix of the services provided by practitioners, the actual impact on total Medicare revenues will be different from what they're estimating. Estimates of the changes in Medicare revenue for physician fee schedule services compared to payment rates in 2014 with proposed payment rates in 2015 that use 2013 utilization data, the payment impacts in the proposed rule reflect averages by specialty based on Medicare utilization. The estimates take into consideration proposed changes in work RVUs, including the impact of changes due to potentially misvalued codes, practice expense, malpractice RVUs, which is primarily driven by the 5-year review and update of the malpractice RVUs. As you can see here, the different specialties and the estimated impact for 2015 based on 2013 utilization of the 2014 fee schedule. The Physician Quality Reporting Services, PQRS, is a pay-for-reporting program that uses a combination of incentive payments and downward payment adjustments to promote reporting of quality information by eligible professionals. CMS released the PQRS specifications for 2015 reporting period, and as expected, they are full of changes. Since inception, PQRS has greatly changed the coding and documentation landscape for eligible professionals and group practices. Reports on quality measures have become a way of life for the practicing physician. Whether the report is being executed through a registry, allowed for most or all standard measures in the measures group, or if the individual physicians are doing claim-based reporting, the additional time and monetary importance is not inconsequential. PQRS kicked off with 74 measures, and in the first year alone retired 50 of those measures while expanding the new measure high to 134. Representation of how far CMS has brought the PQRS system is kind of highlighted in, currently in 2015 we're up to 402 new measures. There was 20, or a new measure high. There was 20 new measures implemented, 53 retired, 14 that are changing from claim-based to where you can only now submit to a registry only. There's 175 total measures available, and there's 71 available for claim-based measures. Now, as always, medical professionals should consider several factors in selecting the measures for the coming year. And some of the more common recommendations by CMS include physicians, commonly treated clinical condition or types of care, the care delivery area for most of their treatment, quality improvement goals for the previous year, and an overlay with quality programs that will be reported on the coming year. Now, additionally, there's no requirement for physicians to change the measures year after year, but each eligible professional or group practice should strongly consider reporting on 9 different measures across 3 of the NQS domains during the reporting period in order, excuse me, for the required reporting minimums. Each measure must also be reported on 50% of the time that the eligible professional Medicare Part B patient visits. So on 9 measures across 3 domains, 50% of your Medicare population. Now also for 2015, physicians are being asked to do just a little bit more. Eligible professionals now are going to have to report new claims-based criteria, cross-cut measures, when at least one Medicare patient is treated in a face-to-face encounter. A minimum of 1 cross-cutting measure is required to satisfactorily report on the 2015 PQRS, and the face-to-face encounter would include outpatient visits, surgical procedures, and in most general office visits. Now, beginning in 2015, a downward payment adjustment will apply to eligible professionals who do not satisfactorily report data quality measures for covered professional services or satisfactorily participate in the QCDR. In the calendar year ruling, CMS is proposing updates to PQRS primarily related to the 2017 PQRS payment adjustment. So for 2016, they will not be paying an incentive for 2015 successful participation. Medicare will begin reducing payments in 2016 by 2% for not successfully participating in PQRS this year. Changes to the number of patients for which practices report measures under the group practice reporting web interface method is moving from 411 with GPs of 100 eligible professionals, and from 218 for group practices of 25 to 99. Excuse me. 25 to 99 eligible professionals are moving to 245, and for all groups with 25 or more eligible professionals. The group practices will also need to report measures from the cross-cutting measure set if at least one eligible professional sees a Medicare patient in a face-to-face encounter. The maintenance of the certification program incentive for calendar year 2014 is in the final year for which this program is authorized for incentive payments. And this is going to require public reporting of the QCDR measure data, sets criteria for joint entry in the QCDR qualification requirements, and changes that the data submitted deadline from February to March 31st, 2016 for the 2015 reporting data. Meeting PQRS in 2015, as it was in 2014, will enable eligible professionals as well as group practices to avoid the stated CMS payment adjustments that are expected for next year. Now, the value-based modifier, it's a CMS-imposed qualifier that provides a differential payment to a physician or a group of physicians under the Medicare Physician Fee Schedule based on the quality of care provided compared to cost during a performance period. It will be applied by Medicare in the calendar year 2015 to payments for physicians in groups of 100 or more eligible professionals who are submitting claims under one single tax ID. The value-based modifier program is intended to provide comparative performance information to physicians as a part of the Medicare's efforts to improve the quality and efficiency of medical care. CMS will essentially use the modifier to either penalize physicians for low quality of care and reward them for providing high quality of care. The modifier is not optional. Physicians cannot avoid the value-based modifier by simply electing not to participate in PQRS. If physicians don't report PQRS measures, then they will be assigned a negative value number. In fact, the best way to prepare for the value-based modifier is to get involved in PQRS as soon as possible if you're not already. This is particularly true for solo practitioners as well as for small groups. The value-based modifier applies only to physician payments under the Physician Fee Schedule. It does not apply to payments that are not made under the Physician Fee Schedule, including those for physicians providing services in rural health clinics, FQHCs, or critical access hospitals in the method 2 of billing. Now, CMS used 2013 PQRS data when determining the 2015 payment impact for groups of 100 or more eligible professionals, and there's no doubt that they will do the same for all eligible professionals eventually. If EPs in groups of 100 or more did not participate in PQRS, or did not participate, in PQRS in 2013, these providers will receive a 1% decrease in Medicare in 2015. If the groups don't report in 2014, then the Medicare payment rate will decrease by 2% in 2016. These percentages may continue to increase over time, but right now it's a flat rate of a -2 for the PQRS initiative. In an effort to align these programs, CMS is separating all groups of physicians with 100 or more professionals into 2 categories based on their PQRS participation. The first category of groups of the physicians includes those that are self-nominated for PQRS as a group and reported at least one measure, or have elected the PQRS administration claims option for calendar year 2013. Groups in this category include those groups that have self-nominated and have met the satisfactory reporting requirements for the PQRS incentive payment, and this category's value-based professional modifier will be set at 0%. Within this category, CMS is offering practices an option to calculate the value-based modifier using a quality tiering approach. Now, this is going to allow groups of physicians to elect to earn an upward payment adjustment for high performance with low cost and be at risk for downward performance or reduced performance adjustment for poor performance of low quality with a high cost. The second category includes groups of physicians of 100 and more that have non-PQRS reported in 2013. This includes groups that did not self-nominate to participate and did not report at least one measure. The category's value-based modifier will be set at -1 for these groups. The downward payment adjustment for 2015 value-based modifier will be in addition to the 1.5% payment adjustment assist under the Affordable Care Act for failing to meet the satisfactory reporting requirements under PQRS. Practices that PQRS report into 2013 and elect qualifying tiering in 2013 to calculate their value-based modifier will have the opportunity to earn an upward payment adjustment for high performance, meaning high quality, low cost, and be at risk for downward performance adjustment for poor performance of low quality and high cost. The value-based modifier scoring methods focus on how the group's performance differs from the national benchmark on a measure-by-measure basis. Now, for payment adjustment year 2017 based on performance year of 2015, the value-based modifier is going to apply to group practices with 2 or more eligible professionals. Currently applies to group practices with 10 or more. Physicians who are solo practitioners and non-physician EPs in group practices with 2 or more eligible professionals and non-physician EPs who are solo practitioners. The value-based modifier payment adjustment for group practices and solo practitioners will be changed for the 2017 payment adjustment year based on 2015 PQRS performance. Now, in a continued effort to align the value modifier with the PQRS, CMS proposed to classify groups of solo practitioners subject on the 2017 value modifier using a two-category approach that is based on whether and how the group or solo practitioners participate in PQRS. Increase in the value-based modifier downward adjustment from -2% to a -4%. Increase in the maximum downward adjustment under the qualifying tiering methodology to -4%. Setting the adjustment to -2 for groups and solo practitioners classified as either low quality average cost or average quality high cost. Increasing the maximum upward adjustment under the qualifying tier methodology to a 4% increase for those practitioners with high quality and low cost. Setting the adjustment to an increase of 2% for classified average quality at low cost or high quality at average cost. And the new category of 2 to 9 EPs and solo practitioners will only receive upward or neutral adjustments as determined under the qualifying tiering methodology. Now, this year's group practitioners is 10 to 99 eligible professionals will face upward, neutral, or downward payment adjustments as determined under the qualifying tier methodology in which they'll fall under. Medicare will now begin to cover the annual wellness business, providing personalized prevention plan services at no cost to the patient. This new benefit provides an ongoing focus on prevention and preventative care management. The Medicare annual wellness business provides an opportunity for healthcare professionals to be reimbursed while providing the necessary preventative care to their patients as required. So some examples would be, billing a diagnosis code of V70.0, the initial average or annual wellness visit of the GO438, which is reimbursed at $172 and is payable once in a lifetime. And then the subsequent annual wellness visit, which are billed at the GO439 and is payable every 12 months. The initial welcome to Medicare visit is payable once within the first 12 months of the patient joining Medicare and cannot be billed on subsequent, regardless if the provider or if the patient changes provider. The annual wellness visit must be performed by a physician or a non-qualified physician practitioner under the supervision of a physician. The initial visit provides prospective payment system and includes documentation of medical family history, documentation of list of current providers regularly involved in the patient's care, measurements of heights, weights, BMI, blood pressure, and other routine measurements deemed appropriate based on the history or the detection of cognitive impairment. In addition, the wellness visit should include a review of potential risk factors for depression, review of functional ability and level of safety, direct observation, screening questions, or a screening questionnaire. Establishment of a written screening schedule and a checklist for the next 5 to 10 years. There is no copay or deductible for this visit. V70.0 is the current ICD-9 diagnosis that should be used while ICD-9 is functioning, and just demonstrating that it is a wellness visit. If during the course of the wellness visit a problem is discovered and addressed, the E&M can be appended. The documentation must show that the 2 visits and clearly just demonstrate that there is a need for the E&M service and medical decision making as well. The average wellness visit can be combined with a standard office visit if significant. Separately identified E&M services are reported, and then the use of the 25 along with the E&M service code if appropriate. Now, for example, a 70-year-old patient presents to the office for follow-up management of hypertension, and it's due to have their annual wellness visit as well. For instance of this, the provider would code the hypertension as well as the V70 wellness visit, and then they would code an E&M service based on the criteria involved there with the 99213, linking the hypertension diagnosis to the evaluation and management, appending a 25, and then they would bill the GO439 for the subsequent Medicare wellness visit pending the V70 diagnosis code at that point. With the wellness visit, orders for colonoscopies, EKGs, diagnostic labs can also be done. Other services may also include bone mass measurements, diabetes screening, ultrasound screening for abdominal aortic aneurysms, counseling for tobacco cessation is another tool that has been given to providers along with weight loss prevention. One of the other changes that's coming on board with Medicare that they recently did for this year is making modifications to the use of the 59 modifier. Modifier 59 is used to identify procedure services other than E&M services that are not normally reported together that are appropriate under the specific circumstances. Now, due to that definition alone, the 59 modifier itself allows usage in a wide variety of circumstances, and it really works as a broad catch-all applicable modifier. It is most often referred as the modifier of last resort because it allows for the overriding and then the bypassing of GPCI edits. Inherently, this invites misuse and abuse. Historically, modifier 59 has been the most frequently used HCFIC modifier, and has subsequently generated the most payer audits, as you would expect. In 2005, a report by the OIG found that 40% of the Modifier 59 claims failed to meet the CMS program requirements, and that resulted in an estimated $59 million in incorrect payments. And the 2013 CERT report projected a one-year error of $770 million in incorrect Modifier 59 utilization payments. As a result, the Modifier 59 is a frequent target for payer audits and is an annual representation on the OIG's work plan every year for a decade. In order to prevent this and to help out, Medicare has come out with 4 new modifiers. They're going to allow with more specificity for separate reimbursement and accurate coding options. Now, moving forward, CMS is going to continue to recognize the 59 modifier, but where applicable, more descriptive modifiers should be used. The XESPU modifiers, as they're referred to, are listed here. XE designates a separate encounter. XS should be used in a separate structure, a service that is distinct because it was performed in a separate organ structure. XP, where a separate practitioner performed the service. And then the XU, which is an unusual non-overlapping services. And here I'll go over a couple of examples of where each of these would be appropriate to use. Where a patient would come in and receive infusion therapy in the morning and then leave the facility later that evening, leave the facility and then return later that evening for another infusion of the same service, the CPT for the infusion of the 9635 would require the XE modifier to be appended to the second service to designate that it was performed in an actually separate visit and a separate encounter. For XS, an example of this would be where a skin lesion of the arm was destroyed via laser surgery, reported with the CPT 17000. Another lesion is biopsied off the leg and reported with 11100 CPT code. For that structure, since it was in a separate structure of the leg versus the arm, the XS modifier would be appropriate to show that the service was actually performed in a separate anatomical site. For separate practitioners, this would be an example of a laparoscopic hernia repair was performed in the morning by surgeon A. Later that day, there were some acute problems. A second surgeon had to come in and complete an appendectomy. That associated with the appendectomy would require the XP to indicate that it was performed by a different practitioner in a separate visit. And then for XU, usual non-overlapping services, this is an area where 2 separate lesions are present that are within the same code set, such as a 4-centimeter lipoma is excised from the upper thigh, and a separate lipoma is excised from the lower thigh. Since the other one is in a separate and overlapping service underneath the thigh, the XU modifier would be appropriate to indicate that these are usual and non-overlapping services, and thus separate reimbursement would apply. So in summary, as we wrap up here, and I know we're kind of running short on time, I do appreciate everyone hanging on to the end. There's a lot of changes coming forward. Some of the changes are immediate. Some of them we need to start preparing for now in order to be able to be ready when future year and future changes come aboard. We need to work to maximize the revenue potential for every single encounter. And I would recommend don't go it alone. Look for a partner, not just an outsourcing vendor, but somebody that you can use to partner with success to continue moving forward to take the changes that we're going to be experiencing within our healthcare environment today. Reimbursement for these services is what keeps the practice in business, and understanding how these changes are going to impact your practice is going to be critical. Your costs are going to continue to rise, and reimbursement continues to go down with the Medicare beneficiary listing through the baby boomer age continuing to expand. The SGR is going to continue to reduce reimbursements, and it's just going to continue to put more pressures on your practice and the responsibility to make sure that you're staying informed, you're staying educated on the changes, and you're maximizing your revenue potential for every encounter. As mentioned before, here is the list of resources that you'll be supplied, and I believe with that I'm going to hand it over to Allison to give the closing remarks. I appreciate everyone's time, and we'll be responding to your questions as soon as possible. Thank you.